see how we can handle this common complaint. All right. Now, headache is pain, and pain has to have some pain-sensitive structures. Since the headache is pain in the head, we have to see what structures in the head are sensitive to pain. On the left side, you can see that the pain-sensitive structures are the venous sinuses and the arteries at the base of the brain, and their major branches. The small branches do not have fibers that carry pain, arteries of the dura, and dura near the base of the brain and large arteries, and all the extracranial structures such as the scalp, the facial structures, and so on. What are the pain insensitive? The brain parenchyma is pain insensitive because we can even do surgery on the brain on a person who's awake without feeling it. The ependyma lining of the ventricles and the choroid inside the ventricles are not pain sensitive. The pia mater, which is the soft meninges on the surface of the brain, are not pain sensitive. The arachnoid is not sensitive either. The dura over the convexities are not sensitive, and the skull itself, except for the periosteum, it is not pain sensitive. The pain is carried by the trigeminal branches, and as we see, it is called trigeminal because the trigeminal ganglion has 3 branches. So these are the 3 twin nerves. That's why it is called trigeminal. One is the ophthalmic, which supplies the eye, the forehead, and up the tip of the nose. And we have the maxillary, which supplies the upper maxilla and the sinuses, and the mandibular, which supplies the lower jaw and the tongue. So these carry the pain into the trigeminal nucleus. Trigeminal nucleus is an extended nucleus that comes from the midbrain or mesencephalon and extends down to the, which is called the spinal tract of the 5th cranial nerve. It goes down to level of C2. This is the caudal part, and this is the rostral part of the trigeminal nucleus. Now, in analyzing the head, we have to consider that there are certain headaches that we call them primary headaches and secondary. What is the difference? Pain is something that is created within the human beings to avoid, it's an alarm, to avoid some noxious event that may happen in the body. So in primary headache, we have this alarm, which is pain, sounding without an underlying significant or serious pathology. The secondary headache, on the other hand, is a true alarm that there is something that needs to be attended to in a different way. So, what are the primary headaches? Migraine is the prototype, tension type headache, cluster headache, and so on. We have the secondary headaches, which include the infections, the bleeding inside the head, trauma, etc. All of these share the same pathophysiology. They activate the small caliber nociceptive neurons. Nociceptive, they feel the noxious stimulation, and it generates and prolongs the headache. Now, the general mechanisms of headache, we can see that traction on the major intracranial vessels, these were all done when a person was, or tested when a person was having brain surgery while he's awake. So traction on the major intracranial vessels at the base of the brain causes pain, distension, dilatation of the intracranial arteries. This sometimes happens during migraine. Inflammation near the pain-sensitive structures, such as the sinuses and so on. direct pressure on cranial nerves or cervical nerves, such as high disc or tumor that compresses the pain-sensitive nerves. Sustained contraction of the scalp and neck muscles is a very common cause of headache. Tension-type headache is always associated with contraction of the scalp and neck muscles, and that stimulates the nociceptive fibers to carry pain impulses inside the nerves that supply these muscles and bring it back to the central nervous system. And stimulation from disease of the eye, such as glaucoma, it causes eye pain, inflammation of the eye, conjunctivitis, and so on, ear, otitis media, and so on, nose, sinuses, sinusitis. All of these are general mechanisms that may be translated by experiencing pain by the patient. Now we go to the primary headache, and the prototype of that is migraine. Migraine in Arabic is called shaqiqa, and shaqiqa is coming from the word shiq, and shiq means half. خذل شقي أو شلل شقي means paralysis of one half of the body. So it is called shaqiqa, and some people call it الصداع النصفي because it frequently affects half of the head, but not necessarily. Migraine is divided into migraine without aura, and which is used to be called common migraine, and migraine with aura, which is classical migraine. Aura is the warning that comes before the headache, and we'll see that. It is a common disease. A lifetime prevalence for females is about 25%, while in male is about 1/3 of that, 8%. The highest prevalence is between 25 and 50 years of age. About 70% of patients suffering from migraine have a history of first-degree relative who have migraine as well. And the mode of transmission is not known. It is not the standard autosomal recessive, autosomal dominant, because there is not one migraine. There are several mechanisms that lead to this final pathway, which is migraine. Migraine can be triggered by several stimuli which do not cause headache in a person who is not susceptible to migraine. People may complain that if they smell a strong odor, a cologne, or any other perfume, they may have a headache. It doesn't need to be a bad sense of smell. A pleasant perfume may cause headache. Stresses of life, of course, causes headache, either tension type or migraine, but if the patient is susceptible to migraine, it may trigger an attack. Menstrual cycle, changes in the hormones, lifestyle changes. A person who is used to working very seriously, and then he finds himself during the weekend that he doesn't have the pressure of work, and migraine then comes because of that lifestyle change to spoil his weekend. Excessive caffeine and exposure to sunlight. Many patients will complain that if we walk in the sunlight, it triggers migraine. In a normal person, sunlight or bright light does not cause migraine. A migraine attack goes in two phases. The prodrome phase, which precedes the pain. The aura is not always present, but it can be present in patients with migraine with aura. In migraine without aura, or the common migraine, it starts after the prodrome. Immediately you start having the pain, and then later on the associated features of nausea, vomiting, photophobia, phonophobia, etc. And then both of them go down, and then we have the postdrome. We will see each one of these. The prodrome, there is mood changes, irritability, depressions, feeling sleepy, feeling apathetic. There are some neurological symptoms like frequent yawning, photophobia, phonophobia, change in vision, blurring of vision, and some fatigue. They may look pale. They may have some swelling because of fluid retention. They may feel some muscle ache, and then they may feel uh, hunger. They crave food, or they may feel anorexic. They don't want to hear about food. They may feel nausea, and they may have diarrhea. Then comes, for people who have migraine with aura, comes the aura. And the aura may be just a small spot on the vision like we have here, or this is the distorted vision that the patient may experience for a few minutes before the headache. The migraine aura, as I mentioned, there are several pathways that may lead to migraine. And some theories say that it is a calcium channelopathy, and some theories it's the mitochondria malfunctioning. Both lead to hyperexcitability and efflux of potassium, and then leads to what we call spreading depression. What is spreading depression? It's a physiological phenomenon that was described in the 20s or 30s by a Brazilian physiologist called Liao, and he experimented on animals where he would expose the brain and drop a concentrated potassium on the cortex, and he finds that there is a wave of hypoactivity, decreased neuronal depolarization, that from the point where it starts and goes forward, and it moves slowly from one set of neurons to other set to other set. It may take about 20 minutes to spread all over the brain. If we take this part and explore it in a bigger way, we can see that behind this split line, we have an area of oligemia. We have decreased neuronal depolarization. That's why we don't have a lot of neuronal activity. While ahead of that, we have hyperemia, congestion of the blood vessel, and increased neuronal depolarization, as it is depicted in this area. Many researchers in migraine think that the aura is very similar to this physiologic phenomena, the spreading depression of Liao. Then headache comes on, and typically the headache in migraine lasts from 3 hours to 3 days, and the pain is unilateral in about half or 2/3 of the patients, but it can be bilateral. So being bilateral does not rule out migraine. 90% of the patients complain of nausea and some constitutional symptoms. After the headache is over, the patient may feel drowsy, may feel difficulty with concentration, may feel depressed, may feel some difficulty in thinking, cognitive changes, or some transient memory loss. The International Classification of Headache Disorders determined that at least the patient has 5 attacks to label him as a migraineur. And the headache attack should be lasting from 4 to 72 hours when untreated. And then the headache has at least 2 of the following features: unilateral, pulsating, pain is moderate to severe, it's not usually mild pain, and aggravation by normal stimuli or physical activity. That's why the patient tries to avoid routine physical activity such as climbing stairs, walking, or even sitting in a bright room. They try to go for a dark room. And during the headache, there is nausea or vomiting and photophobia and phonophobia. And these symptoms, of course, this is a disclaimer that it should not be accounted for by another cause of headache as it is in the list. What is the burden of migraine? About 25% of the patients with migraine, the females, have 4 or more severe attacks per month, which means that they need bed rest during that time. And societal burden, they lose work productivity. About 4% of all visits to physicians are for headache, and about 1/3 of consumption of analgesics that are sold over the counter. The pathophysiology, the trigger for migraine may start in the cortex and then start stimulating the trigeminal nucleus caudalis, and then it may lead to vasodilatation of the blood vessels and local release of, this is a very important substance, which is calcitonin gene-related peptide. It's a peptide that is very ubiquitous in the body. It has a vasodilatory effect, but also it is involved in the generation of migraine. And now the new treatments are focusing on trying to give antagonist for this peptide. So it activates the primary afferent neurons to the trigeminal nerve, and then the pain is felt. In addition to the release of calcitonin gene-related peptide, we have the release of serotonin, which is 5-hydroxytryptamine. And 5-hydroxytryptamine or serotonin have several receptors, several types of receptor. The type 1D, the type 1B are responsible for pain sensation. Several studies found, especially the studies by PET scanning, found that the generation of the pain comes from the upper midbrain, and contralateral to the headache. There is increased activity of the periaqueductal gray material in the brainstem. PAG is periaqueductal gray material. CGRP, as I mentioned, it's a vasodilating neuropeptide. Its level in the serum and the saliva rise during the attack. And if you infuse the peptide in a patient who is susceptible to migraine, it will induce an attack. And triptan therapy, which is the common treatment for migraine, like sumatriptan or rizatriptan, it normalizes the levels of the CGRP, and that coincides with relief of pain. Now, I mentioned that they think that probably some genetic background for migraine. There are rare inherited migraine syndromes, such as familial hemiplegic migraine. It is related to the calcium channels, and the protein is PQ, and it's a results in increase in the presynaptic calcium. The familial hemiplegic migraine 2 relates to a different gene, ATP-A12, and the familial hemiplegic migraine 3 relates to the sodium channel 1A, and it causes persistent influx of sodium. How do we treat it? There are general treatment that we ask the patient. Of course, we ask them to quit smoking. Low tyramine diet. Tyramine is a monoamine that is found in sharp cheese like cheddar cheese and so on. To avoid that, avoid nitrate, nitrite, and monosodium glutamate. All of these are additives to either meat, that are canned meat. They add to it nitrate or nitrite. And monosodium glutamate is a taste enhancer that is frequently not only in Chinese food, but they put them in a lot of crackers and so on to make them taste better. Caffeine has to be limited, and chocolate has to be limited. to reduce stress and to have regular exercise, to maintain a regular meal schedule, because hypoglycemia can trigger a migraine, and to maintain a regular sleep schedule, because any change in the schedule may trigger migraine, adequate water intake, and to keep a headache diary for the physician to be able to tell how the treatment is going. There is a triad in migraine, that the pain causes either depression or anxiety, and that may lead to sleep disturbance, and sleep disturbance in turn causes increase of pain or more migraine attacks. The options for treatment, we either treat acutely during the attack or try to treat preventively. This works quickly and it is taken as needed. This prevents or reduces the number of attacks, and it has to be taken on a daily basis. So it is not something that we choose if the patient does not have frequent attacks. So the treatment during phase 1, prodrome and aura, there is no need for treatment. However, during the early headache, if it is mild to moderate disability, we only rely on over-the-counter analgesic or non-steroidal anti-inflammatory. If it is moderate to severe, we go to triptans like sumatriptan, rizatriptan, and so on. If that doesn't work, we go to the rescue medications. And if it is a moderate headache, we go for triptans, or we continue using analgesic and non-steroidals. There's no need to give anything during the last phase of migraine. So the headache needs to be caught early. The earlier we catch the headache, the more effective our treatment will be. So we use abortive treatments such as acetaminophen, and interestingly, during the attack, caffeine may reduce the pain because it has a vasoconstrictive effect. Non-steroidals, such as brufen or other non-steroidals, triptans, as I mentioned, like sumatriptan. Ditans are new medications. The problem with triptans are less specific for the serotonin receptors that lead to pain. So they also cause vasoconstriction, and they are contraindicated for patients who have heart disease, while the ditans can be given because they are more selective for the receptors, the serotonin receptors that are involved in pain. And these are the old medications, ergotamine and dihydroergotamine, but still they are useful for some attacks of pain. So non-steroidals, they inhibit prostaglandin formation and they reduce inflammation, such as naproxen, ibuprofen, aspirin is, of course, non-steroidal, and COX-2 inhibitor. The newer COX-2 inhibitors also help in the headache. Triptans, they have relative contraindication, as I mentioned, in complicated migraine, in cerebrovascular disease, coronary artery disease, in heavy smokers or patients on oral contraceptives because they enhance the vasoconstriction, or patients with severe hypertension. The patients with migraine may go into chronic migraine, which is very bothersome. It is thought to be because of central sensitization of the pain centers after repeated bouts of migraine. It may be caused by damage to the pain modulating system or changes in the central nervous system due to medication overuse. As we know, the nervous system has the feature of adaptation. So if you increase the amount of analgesics, they become less effective. They adapt to it. Abnormal focal neurological activity, such as in the pain generators, start firing quickly, or persistent activity of the peripheral pain generator, such as cervicogenic headache, become a trigger for migraine. So this is the pain modulating system. The cortex has influence on the periaqueductal gray matter, which may be the first trigger for pain. However, we have the modulating effect of the rostral ventromedial medulla that can turn the pain off and on. Emotional factors and stress turns it off, so it causes more pain enhancing modulation to happen and go to the trigeminal nuclear complex at C2. And here comes the problem with analgesics. Analgesics will impair the function of the rostral impair the modulating function of the rostral ventromedial medulla. The goal of treatment is to reduce the frequency, reduce the impact on the activities of daily living. So prophylactic treatment is indicated in patients with more than 2 migraines per month, or the attacks they last for several days per week, so they impair the productivity of the person, or the severity and frequency that impacts the daily life, or that the abortive therapies are contraindicated, such as triptans in a patient with myocardial infarction or cardiac ischemia, or they are overused or not very well tolerated. So what medications can reduce the frequency? We have 3 categories of medications. Medications that are originally made for seizure medications, but they reduce the frequency of migraine, like topiramate, valproate, gabapentin, and zonisamide. Or medications that are originally for blood pressure, such as beta blockers, propranolol and danolol, and calcium channel blockers, such as verapamil. It's used for blood pressure. However, flunarizine, it's not used for blood pressure, and it's not approved by the US FDA, but it is available in the European market, and it's a very good central calcium channel blocker for reducing frequency of migraine. And then finally, we have the antidepressants, either the old ones, the tricyclics, or the SSRI and SNRI, such as venlafaxine. Patients with chronic migraine may benefit from injection of botulinum, but this is a very laborious type of treatment because it requires about 31 points to be injected around the head and the cervical region. And it is approved if patient has more than 15 headache per month. And it, as we know, botulinum toxin is a temporarily impair the function of the nerve endings. Therefore, it loses its effectiveness after 4 months, and it has to be repeated every 12 weeks. Now we go to a more severe headache, which is cluster headache. Cluster headache is one or the prototype of what we call trigeminal autonomic cephalalgia, or for short, they call them TAC, trigeminal autonomic cephalalgia. Why they call them that? Because it is associated with some autonomic dysfunction. It's pain, cephalalgia, and there is autonomic dysfunction. This is a cluster headache, and the patient has unilateral headache, but associated with it, there is a swelling of the conjunctiva and tearing of the eye and blockage of the nose. There is paroxysmal hemicrania and the short-lasting neuralgiform headache attacks with conjunctival injection, similar to cluster, but it is short duration. This one lasts only for several seconds, less than a minute. Cluster headache may last for about 15 minutes. And there is the other probable trigeminal cephalalgias. Let's talk about cluster headache. Cluster headache, it is called cluster because it comes in clusters, which means that the patient will be free of headache for all year long. And then almost in a predictable way. 1 month of the year, he will have a group of headaches that come on every day. It may wake him up from sleep. It is unilateral. It is one of the most severe. Some patients may beat their head against the wall. Some patients may think about suicide because of the severity of the headache. Some very strong and stout patients otherwise, they will be crying during the headache. So the description of the headache has to be severe, unilateral, orbital, and may last 15 to 180 minutes if untreated. The associated symptoms, one of these associated symptoms is sufficient to call it cluster, conjunctival injection, lacrimation, rhinorrhea, etc. The generator for cluster headache is thought to be different from the generator of migraine. It is in the posterior hypothalamus. This is the generator. Once it is started, it also has activity in the insula, activity in the frontal cortex, but the generator, the first generator, as it was decided by the oxygen-labeled water PET scanning, and these are the composite areas of activation: posterior hypothalamus and bilateral insula and ipsilateral frontal cortex. Cluster headache affects males much more than females, 6 to 1, and it comes in cyclic group of attacks with long remission. Frequency is about 6 per day, which is very bothersome, and strictly unilateral, often periorbital, and it is constant, severe, burning, pounding, boring, etc. It doesn't have to be just a throbbing like in migraine. And as I mentioned, duration from 15 to 180 minutes, and associated with ipsilateral tearing, rhinorrhea, conjunctival injection. It may be triggered by drinking alcohol or during REM sleep. That's why the patients may wake up from the headache during REM sleep being regulated in the periaqueductal gray, and then periaqueductal gray sends impulses to the posterior thalamus and triggers the headache. The treatment, it may be abortive or bridge therapy or prophylactic. Now, oxygen inhalation with a non-rebreathing mask, 100% oxygen, 17 to 12 liters per minute for about 20 minutes in the sitting position may abort the headache. The mechanism is not known. Unfortunately, only 60% of patients may respond to this treatment. Now we move to another primary headache, which is the tension type headache, equally frequent. So if we say this is the tension type headache, this is the migraine, and this is the cluster headache. These are the size of the problem. Tension headache may last from 30 minutes to 7 days, and the pain is pressing, tightening. The patient may call it like there is a band around the head. It is usually bilateral. It's not aggravated by physical activity. The patient, you ask him, can you continue working? Yes, I can continue working, but it's very bothersome. There is no vomiting with it, and no more than one of the either nausea or photophobia or phonophobia. If they are coming together, it is more likely to be migraine. And history and physical diagnostic tests do not suggest any underlying cause for the disease. So the diagnostic criteria need 2 of the following: pressing, tightening quality, mild to moderate intensity, bilaterality, or no aggravation by normal activity. And the associated symptoms, it should have no nausea, it should have either one of these 3. Any more than one makes it not tension type headache. Treatment, acutely, like in migraine, we give analgesics, and sometimes muscle relaxants may help. And in chronic treatment, we give tricyclic antidepressants and physical therapy and exercise program may reduce tension type headache. Medication overuse headache is important because many patients, since the medications are over the counter, they take the first pill, doesn't work, second, third, fourth, and then they go into excessive use of medications. The problem with analgesics that when it stops working, it may cause aggravation of the headache in a rebound phenomena. It is defined, the medication overuse, it's defined as the headache will be present more than 15 days per month, and the person may be using the or overusing analgesic for over 3 months and markedly worsened with this medication overuse. The etiology is uncertain, but it is present in patients who are predisposed to headache, and probably those patients have chronic low serotonin level or elevated levels of calcitonin gene related peptides and central sensitization. How do we define what is the threshold by medication? About simple analgesics, if the person uses simple analgesic 15 or more days per month. Combination pain medication, there are some combination like Tylenol extra that has caffeine in it and so on, if they use them 10 or more days per month. Prescription migraine medications such as sumatriptan, rizatriptan, 10 or more days per month, that's overuse. Or patients who use opioids, and opioids include solpadine, which contains codeine. If they use them 10 or more days per month, that's an overuse. So in order to get over that, the patient must stop it. It may be difficult at the beginning, but it has to be, it's a step that has to be taken. Discontinuation after a few days, it will result in significant improvement, and the response to pain medications later on becomes returns, and they will have a response when they have a regular headache and they take analgesic. So migraine, which becomes chronic migraine with medication overuse, it may be converted to episodic migraine. The physiologic changes, as I mentioned, it may decrease the serotonin level. The serotonin receptors may be upregulated, and there is increased central responsiveness because of decreased release of CGRP, because of increased release of CGRP. And we know that opiate exposure increases the response of the afferents when stimulated pain facilitation in the rostral rostral nucleus of the medulla. The overall approach to primary headache, we take the chief complaint, we decide if it is primary, we diagnose the primary, then we treat as primary. If it is not, we have to go to the secondary. So in the history, we have to ask the patient if that is the first headache or the worst headache, that is a red flag. If it's accompanied with new or frightening features, how did it start? Have been previous headaches? If there is previous headaches, then that's more reassuring. Where does it hurt? Is it unilateral, bilateral? What is the character of pain? Is it pulsatile, shock-like, tightness, associated symptoms that we mentioned? All of these we can take from the history, and about 90% of the diagnosis in headache comes from the history, because clinical examination is normal, and if you find something in clinical examination, it is a secondary headache. What are the relieving factors? What are the medical history? Does the patient have HIV, cancer, hypertension? Did he have a recent lumbar puncture? Has he changed his medications? Family history, especially with migraine. Have they been exposed to carbon monoxide, which is common in winter month? Then the physical examination, we try to see if there are any localizing signs or any changes in the head structure, such as the eyes and in the ears and in the temporomandibular joint. Diagnostic alarms if the patient has onset after the age of 50, if it is a sudden onset, if it is increased significantly in frequency and severity, and if the patient has risk factors such as HIV or cancer, if there is fever, meningismus, or rash, if there is change in consciousness, if there's papilledema or significant trauma in the past. So we do we do computerized tomography if there is suspicion about a secondary headache. We may need to do lumbar puncture if it is meningitis or hemorrhage. The MRI or MRA or angiography have some limited indications when we are suspecting a certain thing in particular. So that brings us to the secondary headache, and these are the common associated conditions. Hypertension, the characteristic is bilateral, throbbing, and increased with activity. It is usually associated with late pregnancy, like in eclampsia, and it's associated with anxiety, sweating in pheochromocytoma. This is the hypertension headache. These are the pheochromocytoma. This is the kidney. It is usually, as I mentioned, bilateral and throbbing. And hypertension, people wonder whether it's a coexistence of two common conditions, headache and hypertension. However, severe hypertension may be the cause of headache, like in pheochromocytoma or in eclampsia, or extravasation from cerebral blood vessels because of hypertensive encephalopathy. Associated condition, this is meningitis, and of course that's a serious problem that needs to be treated, diagnosed by severe headache, knuckle rigidity, and inflammatory response on CSF in lumbar puncture. Subarachnoid hemorrhage, this is a CT scan of subarachnoid hemorrhage, and we see that there is fluid increased density, which is blood, within the interhemispheric fissure and in the sylvian fissure. Subarachnoid hemorrhage happens, fortunately, not very common. In a 10,000 per 100,000 of the population, we have only 10 cases. The mean age is about 50. Usually the patient says, this is the worst headache I ever experienced, and it came all of a sudden like something snapped inside my head. The risk factors is genetics, if there is a first degree relative with subarachnoid hemorrhage or polycystic kidney, and if the person smokes or consumes ethanol. About 50% may have a warning bleed, and if that happens within 2 or 6 weeks, a full bleed happens, or rebleeding, and rebleeding may carry about 50% mortality. Head CT is negative in a few cases, and the sensitivity decreases if time have passed over the headache, because the blood will get mixed with the CSF and loses its density. Thunderclap headache. Thunderclap headache is something like a thunderbolt that comes over the head. It's a sudden onset with maximum intensity about 1 minute, and it may last for 1 hour, and it may continue for 10 days and does not recur regularly, and it's not attributed to another disorder. Always we have to make sure that there is no underlying cause. So thunderclap headache, like lightning, aneurysmal subarachnoid hemorrhage is the first consideration. Unruptured cerebral aneurysm with a sentinel bleed, and carotid vertebral artery dissection may cause thunderclap headache. Cerebral venous sinus thrombosis, pituitary apoplexy, which is bleeding inside the pituitary gland. Reversible cerebral vasoconstrictional syndrome, which happens with some medications or with increased blood pressure, or CSF hypovolemia syndrome. Subdural hematoma is collection of blood in the subdural space, and as we can see here, this is the diploic space of the bone, and this is the dura, and this is the arachnoid. The subdural is in this level. Now, subdural hematoma occurs after head injury, but the head injury may be minimal or severe, and it is caused by the bridging vein subjected to traction because of the shearing effect of the head trauma. And this is the bridging vein, as we can see it. It bridges between the sinus and the surface of the brain. Risk factors are old age, because with old age we have shrinkage of the brain, so the skull will be too wide for the brain, so it will allow the brain to move back and forth inside the skull. Ethanol also causes extra shrinkage of the brain parenchyma and causes the movement of the head back and forth with minimal trauma. If the patient is receiving anticoagulants or has a bleeding disorder, and as I mentioned, trauma may be mild to severe. This is subdural hematoma as seen on the CT scan. Presentation may be subtle with headache, hemiparesis, aphasia, etc. Temporal arteritis is another cause for headache in elderly patients, and temporal, it's called cranial arteritis. It's a systemic inflammatory vascular syndrome and predominantly affecting the cranial arteries of the elderly. It may cause pain in the scalp, tenderness over the scalp, and jaw claudication. That means when he chews, he have pain and cramp and he has to stop. Decreased vision secondary to arteritis, and this is the risk of granulomatous arteritis of the temporal artery, because it may affect the central retinal artery and cause infarction of the retina. This is the temporal arteritis. The artery is enlarged and indurated, and there are some lumps over it that can be felt, and it loses its pulsatility because the lumen is occluded. The complications for polymyalgia rheumatica and giant cell arteritis is the same, two names for the same condition. The major thing is loss of vision, but it can also cause stroke or gangrene of the tongue or scalp necrosis. The diagnosis is made by artery biopsy, temporal artery biopsy. Treatment is with corticosteroids, but once it is started, it has to be continued. It has to be in a good dose, 60 milligrams daily, and the relief may not come immediately, but in a few days. And it has to be continued after confirmation with a biopsy for about 2 years. And then it is withdrawn slowly. And we follow the parameters, the clinical condition of the patient by the elimination of the headache. Erythrocyte sedimentation rate usually is part of the diagnosis. When the patient comes in with pain in the temporal region, we check his ESR, and usually it is above 80, 60, 70, 80, etc. And we also check inflammatory markers like CRP or ESR. Rarely we require immune suppression. We may use azathioprine to reduce the need for corticosteroids. We go to the zoster, and zoster is caused by the varicella virus. It's one of the herpes viruses, and the patient may present before the rash with a unilateral headache, and particularly around the forehead, around the ophthalmic branch. The zoster increases with age. As aged people, they will lose their immunity to the varicella, immunity that they have gained by infection in childhood or vaccination. Or they may have neoplasm or lymphoma that will reduce their immunity, or they are immune compromised by AIDS, or they are transplant recipients that have that are taking medication to reduce their. And maybe with varicella vaccine being given to older individuals will reduce the zoster ophthalmicus. The problem is that even after the rash disappears, the inflammation of the nerve may cause persistent neuralgia, and post-herpetic neuralgia is difficult to treat. How do we treat zoster ophthalmicus? By antivirals, acyclovir or famciclovir, and pain control with tricyclics or gabapentin pregabalin. Low or high CSF pressure, idiopathic intracranial pressure typically happen in young women who are obese. They complain of headache, and they may have either transient visual obscuration, that when they change position, suddenly their vision will black out for a few seconds and come back. Or they may hear intracranial noises such as pulsatile, low frequency tinnitus in their ear. It goes like the signs. Once we have these symptoms, we look inside the fundus and we find papilledema. Once we find papilledema, that's a sign of raised intracranial pressure. If we do visual fields, the patient is not usually aware of change in their visual field, but we follow the patient with serial perimetry. There might be an enlarged blind spot, which is the reflection of disc swelling and elevation in the fundus. The treatment, most important treatment, is to preserve vision. The most important side effect of raised intracranial pressure is loss of vision. Otherwise, it doesn't have much more side effects. And so we also need to alleviate the symptoms of headache. How do we do that? By either CSF drainage or by giving drugs that will reduce the secretion of the CSF, or we remove the possible cause. Some patients who may get that because of taking medications such as vitamin A derivatives or tetracyclines. And weight loss, if the patient is overweight, losing 5 kilograms may relieve the intracranial pressure. The treatment with medications, carbonic anhydrase inhibitors such as Diamox, loop diuretics such as furosemide, and repeated lumbar puncture. Rarely we have to do corticosteroids or to ask the surgeon to do lumboperitoneal shunt to remove the extra CSF. Sometimes increased intracranial pressure may be associated with cerebrovascular or cerebral venous thrombosis. And as we can see in this picture, there is occlusion of the venous sinus here and occlusion of the venous sinus here. So in this angiogram, the dye has accumulated in the open part of the superior sagittal sinus. Then it goes inside the diploic veins. Then it goes into the scalp veins. So why do the CSF pressure increase? Because when you have increase in pressure in here, then these arachnoid villi will not drain the CSF. In normal situation, if there is low pressure here and there is high pressure inside the arachnoid, subarachnoid space, which contains the CSF, then these arachnoid villi will start leaking the CSF in the circulation, and then that is taken to the kidneys. But if the pressure over here is high, then this will be occluded. These are the arachnoid villi. Now, the last one of the associated symptoms with headache is epilepsy. We know that headache is very common post-ictal symptom, and headache is rarely the presenting symptom of epilepsy. And epilepsy happens in patients who are suffering of migraine. It is about 10 times more frequent than the general population. And the migraine history may be found in about 24% of epileptics. And anti-epileptic drugs are effective for prophylaxis of headache in migraineurs as well as in epilepsy. The most effective prophylaxis for the headache associated with epilepsy is valproate and topiramate. I think this is the last slide, and I'll be ready to have any questions. Thank you.